Good afternoon, everyone. I'm very happy to be here with you again. My name is Caner. I'm working at the Department of Anesthesiology and Intensive Care in the university. And I'm just like everybody else, I'm in this translational medicine program because I want to see a generation of bedside scientists who is going to replace habit in clinical practice for scientific mindset. Now, over these 15 months, I think I was privileged enough to experience most of the beautiful challenges of conducting clinical science. We have faced all kinds of different challenges with all three of our different projects. And it would be my pleasure to share my experiences after 15 months with you. I chose to work on liver diseases in the context of anesthesiology and intensive care because of its special pathophysiological challenges. So I have three studies which take into consideration three different settings: preoperative, perioperative, and if things go wrong, the ICU setting. My first project is about the preoperative administration of glucocorticoids to reduce complication rates in a liver surgery. Liver surgery is still quite dangerous for patients, and we think that dysregulated immune response to the parenchymal injury plays a role. So in the literature, there has been many suggestions of using immune modulators, such as steroids, to overcome this challenge. The premise of our study was that in 2016, preoperative glucocorticoid administration was recommended, but there was not really enough evidence. And since then, more studies have come out. And the interesting thing is that the latest meta-analysis on this topic in 2021 found this beautiful p-value, which was statistically significant, and they were getting ready to recommend to every clinician that we should administer glucocorticoids. But then, with 4 new RCTs and 400 new patients, we have discovered that the improvement is not statistically significant. So maybe we should reconsider this and try to generate more evidence. And this was our aim, to see the effects of steroids in these patients. Now, our main outcome was the overall postoperative complication rate. And here, with an odds ratio of 0.71 and a p-value of 0.23, we have saw that there is a tendency for lower complications, but we need further research. We also checked some other complications specifically, but we did not see any significant difference in any of them, except for wound infection, which is quite surprising. And this is the beautiful thing. Science is full of surprises. I personally did not expect this significant difference in wound infection, so I think this should be also further researched. When it comes to perioperative outcomes, we have also seen that there is no statistically significant change either. And we have also realized that plenty of laboratory outcomes, because this is liver surgery, and liver is responsible for most of the chemicals that are going around in the body. One would assume that we would have a good level of evidence for these laboratory outcomes. However, in the literature, there was a distinct lack of quality when it comes to this evidence. So we could not meta-analyze it. So in conclusion, as I said, we would rather not strongly recommend that people should use this administration, but it is very clear that there is a promise in this field, and properly designed clinical trials might answer many of the questions that we still have on this topic after almost 20 years of research. And as a summary of what made this paper special: largest patient pool, we only meta-analyzed RCTs. I think most of the projects that we have heard about today share these strengths. And as a limitation, we could not perform subgroup analyses, and we could not meta-analyze laboratory outcomes. As I said, we should, in practice and in research, we should reconsider this whole topic in the light of new evidence. We have submitted this manuscript to the Annals of Surgery in October, and we are still waiting for the journal to make their decision. My second study is about hemadsorption therapy for critically ill patients with acute liver dysfunction. Now, critical illness, as the name implies, is quite dangerous. But with acute liver injury or any kind of liver dysfunction, what might basically happen is that the patient goes into a deterioration cycle and they cannot recover from this. We have several treatment options, but these are either unfeasible or not successful enough. So we can manage the complications, we can bridge patients to liver transplantation, or we can keep them alive in the life support until they recover. Hemadsorption is a novel strategy in life support systems. And basically, we chose to investigate hemadsorption because at the same time, it addresses all three of the treatment options that we have available. So our aim with this study was to summarize and synthesize the evidence available for this novel strategy. We were primarily interested in mortality, liver function, and cytokine levels as markers of liver deterioration or recovery. And we have shown from cohort studies that there is a statistically significant difference when utilizing hemadsorption therapy over control. And by control, I mean standard of care. The post-treatment total bilirubin level decreased significantly, which is good news for anyone who might want to consider an alternative treatment for a patient with liver dysfunction. We have also seen some quite promising results from pooled data of case reports. We have seen that with vasopressor need, so circulation support, and with ALT, there is a very significant change post-treatment. With AST and total bilirubin, we are not so sure that it's statistically significant, but I think further research will clarify this issue. And here we are finalizing the manuscript, and we will submit it for the internal review before the end of the year. And my third project is about goal-directed fluid therapy in liver surgery, which is why I was asking my dear colleague Panni about why limit your study in pancreatic surgery. Because we can argue about this in the coffee break, but I think it's the liver that is the most sensitive for fluid changes. And basically, there is always a sweet spot, a golden ratio for managing fluid for patients with failing livers or injured livers, as in the case of liver surgeries. And the mortality and postoperative complication rate are really high, which necessitates that we find a better way to manage these patients perioperatively. The problem that we are facing with this study is that goal-directed fluid therapy has historically been a very interesting topic for surgeons and anesthesiologists alike, but there are simply so many alternatives and so many goals, let's say, to direct the studies towards. And in other surgical fields, there are already quite well organized and published network meta-analyses that show very promising and very supportive results in favor of GDFT. But liver is infinitely more complex when it comes to this subject. So there are no studies, no meta-analyses, no systematic reviews when it comes to GDFT in liver. And this is what we would like to do, with a particular focus on postoperative complication rates. So over these 15 months, I think I have seen the good, the bad, and the ugly of translational medicine. And I am quite confident that the continuing scientific work of all of our colleagues are going to translate into clinical practice, given that we overcome these challenges. Thank you so much for your attention, and I'm expecting your excellent questions.
My question is about the first topic. That have you seen any common feature in the papers of positive or negative results? Just to where to go and how to find clarify about this question.
This is a fantastic point. it is a given that we need to clarify the evidence that's available. And one of the nice things about making a systematic review is that it's not only about maths, but it's also about a qualitative assessment of what we are dealing with. And what I have realized is that in this topic, usually the studies with the most promising results tend to be those ones with the most issue with the precision of the evidence. So these fantastically positive results with these nice p-values, it is a question mark whether these results are generalizable or not. So it is very difficult to say that the same results for patient's benefit will be reproducible when we are focusing only on liver transplant patients, or when we are focusing on patients who have failing livers because of some kind of, let's say, a viral infection. So the precision is the biggest issue, and therefore their common feature is that they don't really make a distinction.